Hello everybody, my name is Micah, lead pharmacist at LPN. In today's video, I'm going to be talking to you about stroke and some of the changes in the guidelines on the management of stroke. Okay, so for the purpose of this video, I'm going to be talking for the perspective of a day one pharmacist, a newly qualified pharmacist. What are some of the key things you need to know as a newly qualified pharmacist? Okay, so the first thing you want to know is the symptoms of stroke. What are some of the basic symptoms that you would see to help you recognize when a patient is having stroke? The first thing is slurred speech. If a patient has slurred speech, they're probably having a stroke. Face drooping. Face drooping is another example. Another one is their arms. If they're unable to move their arms, they could be having a stroke. Numbness is another symptom. Paralysis is another symptom. Confusion is another symptom. Okay, so those are the main symptoms of a patient who is having a stroke. We have numbness, we have paralysis, we have confusion, we have face drooping, we have slurred speech, and sometimes they're unable to move their arms. The next thing you need to know are the types of stroke. Okay, so for the purpose of a day one, a newly qualified pharmacist or a trainee pharmacist, you need to know three types of strokes. So the first one you need to know is called hemorrhagic stroke. The second one is called TIA, which is transient ischemic attacks. And the third one is called ischemic stroke. And under ischemic stroke, we have two types. Okay, so we have minor ischemic stroke and major ischemic stroke, which some people call disabling or debilitating ischemic stroke. Okay, so we have three types of stroke. Once again, we have what we call hemorrhagic stroke, we have TIA, transient ischemic attack, and we have ischemic stroke, which is split into two: minor stroke and major stroke. So in the UK, about 85% of patients who have a stroke every single year would have either a TIA or ischemic stroke. Obviously, ischemic stroke is the most common one, and about 15% of patients will have hemorrhagic stroke. All right then, so with hemorrhagic stroke, for the purpose of the GPSC exam or for a trainee pharmacist point of view, you're going to have to know a few basic things. The first one is that when a patient has a hemorrhagic stroke, we are going to find out or make sure by doing what we call a CT scan. Okay, so we do a CT scan and we find out where the hematoma is or where the blood clot is. As soon as we identify that, we're going to get a surgeon in who's experienced to remove the hematoma via a surgical operation. We're also going to try and maintain blood pressure. We're going to try and ensure that blood pressure is between 130 to 140 millimeter mercury. That is their systolic blood pressure. Also, in terms of medication, which we need to know about, when a patient has hemorrhagic stroke, we're not allowed to give them any antiplatelets. So no aspirin. We're not allowed to give them any anticoagulants. We're not allowed to give them any statins. We're not allowed to give them warfarin. We're not allowed to give them any of these things except in small number of cases where a patient has a high risk of VTE or DVT or PE. Okay, so for patients who have hemorrhagic stroke, is a specialist area, and those are the basic things you need to know. The next group we need to talk about is TIA and patients with minor ischemic stroke. Okay, so if a patient has TIA or minor ischemic stroke, the first thing we're going to do is to give them aspirin 300 milligrams. We need to give them aspirin 300 milligrams within 24 hours of stroke onset. Okay, so if the patient is not allergic to aspirin or unable to tolerate aspirin, give aspirin 300 milligrams. If they are unable to take aspirin, then you give another suitable antiplatelet drug. If the patient does have an ischemic stroke, one drug we can give is called Antiplatelets. But Antiplatelets should be given within 4.5 hours of the onset of stroke. So I'll say that again. If you give Antiplatelets, it has to be given within 4.5 hours of the onset of stroke. When a patient has stroke, we are going to look at giving them long-term antiplatelets. Okay, so we have to give them long-term antiplatelets to prevent the possible risk of blood clots forming again, and so on. So we're going to put patients with a low risk of bleeding on what we call dual antiplatelet therapy. Okay, so in the new guidelines, it says put patients who have a low risk of bleeding on dual, which means 2 antiplatelets at the same time. So we're going to put our patients on aspirin plus clopidogrel. Okay, so put patients on aspirin and clopidogrel at the same time. And if you're going to do this, they're going to be on aspirin for 21 days only. They will stay on aspirin for 21 days. And after 21 days, they will stop aspirin and continue with clopidogrel by itself. So I'll say that again. Take aspirin and clopidogrel together. Take aspirin with clopidogrel for 21 days. After 21 days, stop aspirin and continue with clopidogrel by itself. If the patient is allergic to clopidogrel or is unable to tolerate clopidogrel, we're going to use a combination of ticagrelor and aspirin. Okay, so we'll combine ticagrelor and aspirin. But note this, if a patient is going to be on ticagrelor and aspirin, you need to stop aspirin after 30 days. Okay, so in the first case, clopidogrel and aspirin, we stop aspirin after 21 days. In this case, ticagrelor and aspirin, we stop aspirin after 30 days and then continue with ticagrelor by itself. Okay, so if the patient is unable to take 2 drugs at the same time, then we're just going to give the 1 antiplatelet therapy. So we're going to give clopidogrel by itself, or ticagrelor by itself, or aspirin by itself, whichever one they can tolerate. Okay, so those are the basics. Then on top of that, in the new guidelines, when a patient has had a stroke, we need to put them on statins. However, before we used to put patients on statins after 48 hours or within 48 hours of having a stroke, but nowadays we'll put patients who have had minor ischemic stroke or transient ischemic attacks on atorvastatin 80 milligrams, for instance, as soon as they can swallow. So I'll say that again. If a patient has had TIA or minor ischemic stroke, we're going to put that patient on statins like atorvastatin 80 milligrams as soon as they can swallow, rather than within 48 hours. Also, in terms of long-term management, we use the mnemonic BBC. Okay, we use the mnemonic BBC as part of our long-term management. So the first B stands for their blood. Okay, so we're going to put them on antiplatelets for their blood to prevent and reduce the risk of blood clot formation. Okay, so in terms of B, we've spoken about it. Antiplatelet therapy, we're going to combine 2 drugs wherever possible and stop aspirin after 21 days if combined with clopidogrel. Stop aspirin after 30 days if combined with ticagrelor. We're also going to put the patient on antihypertensive. So the other B stands for blood pressure. So we check their blood pressure. If the patient has hypertension, if they have hypertension, we're going to put them on a suitable medication for hypertension. But remember, do not initiate beta blockers. We're not allowed to initiate beta blockers after a patient has had a stroke. If the patient was taking a beta blocker before they had a stroke, they can continue with their beta blocker. However, if the patient wasn't on a beta blocker initially, we shouldn't start a beta blocker. Okay, and the last one, which is C, is for cholesterol. Okay, cholesterol, we're going to put them on atorvastatin 80 milligrams, okay, to reduce the buildup of plaque and arteriosclerosis. Okay, so those are the main updates within stroke management. I hope this video helps you. Thank you so much for watching. See you soon.